So I like to take certification exams, but I'm also a clinical nurse specialist. So that makes, the problem is I can't see any of you guys. I don't know where everybody went. I gotta figure out, I can't see any faces. Do you know what I did wrong?
We're here.
You're there. Okay, I'll just have to figure out where you guys went. So I can't get a lot of feedback. I don't know. We'll have to figure that. I'll have to figure out what I did wrong. And my nursing career has
Sarah,
been, what?
I'll watch your chat. I'll watch this is Heidi's voice. I'll watch the chat for you. Yeah.
People's facial expressions. So my nursing career's been I graduated from a diploma program, and I have 2 degrees from the University of Minnesota, and I cannot say enough wonderful things about the University of Minnesota School of Nursing. But my nursing career has been, I'm kind of unusual for my age. 43 years I've been a nurse, 42 of the years I haven't worked in a hospital. So I started working in geriatrics in nursing homes. Then I went to work in correctional health care, public health, and then I went back to working in geriatrics. And I also and now I'm a faculty. I've been a nursing faculty since, 2003, but full-time since 2010. So, and I'm trying to figure out what I want to do in the next phase of my life. So, and I've been very active in organized nursing. It was fun to see David here because I remember David when I was president of MNA. So, world, right? Yeah. So I prepared a PowerPoint. It may not be as comprehensive as I would have liked, but I would like people, like I said, I can't see people and I don't know what I did wrong. That usually I can see people on the edge, and I don't know, I must have done something wrong. Usually I can see. What?
Maybe if you exit full screen, you might be able to see people.
Exit full screen, but I got to figure out how to do that.
Okay.
Well, you know what? We'll play, here, let's do this.
Just keep rolling. Okay.
Just go up to, Sarah, go up to the right where it says view, the right corner.
Yeah, what?
Where it says view.
Well, do you see
And
me
then
now?
you choose the gallery view.
Because
Huh?
way up in the very right corner, it says view, then you can exit the full screen, way in the corner.
Well, I don't know what I'm doing wrong.
Way.
Isn't it? We'll see. We'll try it again. We'll get Sara back. Just give me 1 minute. I got to get my PowerPoint. They're going to love this. Oh, what the heck happened to my PowerPoint? Now it disappeared. So let's just stop sharing. I had practiced for this. I want you guys to know. Now that's kind of interesting. My PowerPoint disappeared. So just give me 1 minute.
You're with friends. Take your time.
Well, I hate it when we have technical difficulties. So we're going to try this again. You guys are you're being kind of generous with me. So let's just do this. We're going to share my screen. Do you guys have a problem if you, it says the video thumbnails are minimized to optimize full screen video clip sharing. Do you guys mind if you just see my slides from this way, or do you want to see the slideshow? Is it better, Kathy, to
No,
do the
that's
slide?
fine.
Huh?
I think
Okay.
that's fine if that's okay for you.
Yeah, I just can't still see everybody, but I don't know what I did. Well, you know what? Maybe if I can't still see you, I'll just do it this way. All right. So I have no financial disclosures, so I'll tell you that. So I don't know everybody here, but I just want to let you know that I try to be informal. So if you have something that you would like to talk about, I'd rather that you just interrupt me, and you don't have to put it in the chat. I don't know if you have any rules about that, Kathy. I think it's fine to just have a dialogue. And these are my objectives, which I'm not going to review, but being the good nurse educator and to get your continuing ed, you have to do. So I want to tell you a little story about helicopters and older adult healthcare. So my clinical practice, that's something I forgot to say in my introduction, is at Essentia Health. I work in the neurology clinic with a lot of dementia and memory care patients. And tomorrow's my clinical practice day, and I'm usually there till 8 or 9, trying to finish up my charts. I often see patients late, but I have a window that faces the lake, so I get to hear all the helicopters come in to St. Mary's Medical Center. And I really am very saddened because I know that many of them contain older people who really don't want to be in that helicopter. And I feel like we need to figure out how to fix our healthcare system. And that's what I want to talk about a little bit today. So it's more age friendly and we can help keep some of those people out of the helicopters. So, and I'm clearly have a bias against that, but I had a friend, I have a colleague who's a helicopter nurse, and he said that part of the reason a lot of our older people get put on helicopters is in the rural ERs, the emergency room doctor calls the Essentia ER or whatever ER. And if they want to try to not take the person, then they'll find another ER that'll take them. And so my goal is to keep people out of the ER. So that's just my story. So I think many of you have seen this graphic, but we have a demography where, and in just 2034, so 11 years from now, so I'm still going to be young, the number of adults 65 plus is going to outnumber children by in that year. And that's the first time in US history. So that really is going to present some challenges for us. Do you guys have any thoughts about what some of the challenges might be?
Paying for care.
That is good point. Yes, paying for care. Do you remember? I think it was
healthcare workforce.
Oh yes, the healthcare workforce.
You know,
we don't have one. Yeah.
Yeah, exactly.
Do you remember? I think it was in 2022, the Medicare rates went up a significant amount for people. Do you recall that? That was all due to the new dementia drugs that are coming out, like aducanumab and lecanemab, that are very expensive. So there is going to be a lot of costs. So that's, but I think this is just really kind of frightening. So I think the other thing to remember is that comparing 2019 and 1900, certainly the 65 to 74-year-old age group has increased. But look at this, the 85 plus group is more than 53 times larger. So we're living longer and we have really unique needs. And I tell people that I find 85 is the magical age. You can survive a lot, but when you get to be 85, things really start to kind of break down. So, and I tell all of my patients, and I've had this personal experiences, I usually say there's two parts to your retirement. If you get to have a good retirement, is the first maybe 10 to 20 years, you could kind of do what you want to do. And then the second part, often at 85 plus, you need to make a different plan. My father, many of you know, my father lived with me for 3.5 years and he didn't have a plan. So he came up to Minnesota or Wisconsin on a vacation and stayed for 3.5 years. So, and that worked out for him. And then the other thing is we talk about this change from in 1960 to 2060, the pyramid in terms of the ages, you see how few people made it to 85 plus in 1960 and look at it, what in 2060, how it's more going to be more even. So that's also significant. So, and this just shows the population by count, by state. What's interesting is, the darker green is 19 or more %. You look at Maine, up in Maine, and look at Pennsylvania and West Virginia. Not surprised about Florida. I actually thought Minnesota was going to be higher. Anybody else surprised by anything here or not?
I agree with you, Sarah. I thought Minnesota would have a higher age demographic than that.
Yeah, in St. Louis County, we have a huge thing, but I thought it was just surprising. This is the poverty rate, and I think this is really important to keep in mind. Minnesota, we're not so bad. We're 8 to 9% poverty, but look at some of the states where there's significant poverty. Not surprisingly, it's the southern states, but just something, and South Dakota. South Dakota is sort of an outlier here, but they also have, you know, the Pine Ridge Indian Reservation. So that may be something that contributes to that. And then older and growing, and this shows where the older population is changing. I was surprised when I looked at this, I was surprised how many were in the Twin Cities. Because like we've been told it's St. Louis County, but I was just kind of intrigued by that. The percent change, you know, look at that. It's the purple is 60% increase from 2010 to 2019. And the surge in the number of Americans aged 65 and older this decade has outpaced the growth in the working age population. And we know that the growth of the non-working age dependent population, people under 14 and 65 and older, has outpaced the working age population. And so that leads to something called the dependency ratio by county. And that's a significant thing because it means that we have less people paying into the system to take care of us and to pay the bills. So I think that's kind of intriguing. And then we also have a much more diverse nation. Right now, we still have a large number of non-Hispanic whites. You know, it's primarily non-Hispanic whites, but that is going to change. And I have some more statistics moving along. And that's one of our challenges as we move along that we're going to need to deal with and address more effectively is the diversity. And we know that our racial and ethnic minorities increased, like we said, 20% of older Americans in 2019 and 24% of older Americans that are projected to increase to 34% of older adults. So we're going to have the white population from 2019 to 2040 is going to increase by 29%, but racial ethnic minorities is going to increase 115%. And it just shows some of these groups, particularly the Hispanic and African American and American Indian and Asian American, not Hispanic. So we're gonna need to be addressing that more effectively. Now I'm gonna hit a pause. What kind of thoughts or feedback do people have?
I think one of the things that I was thinking about is there's so many people that in those years are going to be dependent on Social Security, and with less and less people working, that's a system that may not work for those generations coming behind us.
Well, I'm going to say a very radical thing about Social Security. In 1935, the greatest population that was living in poverty was older people. And I think people died at 65. So one of the things they did was develop Social Security to keep people out of poverty. Social Security was never intended to be the main retirement resource. And I think during my lifetime, we're going to have to go to a means testing of Social Security. Any civilized society has a means and a process to support those who are lesser abled. And when I say that, people think I'm really like I have horns growing out of my head, but right, I don't think Social Security is going to be able to keep up. And the population that's living most in poverty, and I think Heidi found this out when she did her DNP project, is children. That is a problem.
Yep.
So yeah, economically, we're not going to be able to do what we need to do. So other feedback?
Yeah, one thing, Sarah, and this could be something that, is put on a parking lot, but a lot of research I've been reading about that America doesn't do particularly well, but European countries do, is how we support lonely elders.
Yep.
Because from what I read, and you are certainly the expert, loneliness is a huge health risk.
It is, yeah, I've
more
done
so
many,
from what, yeah, and yeah.
I've done
So
many
I'll let you kind of
presentations on,
speak to that.
oh yeah, that's a huge issue. I've done like a half dozen presentations on loneliness in older adults. It's a huge problem. But you also have to look at, like, when you compare Europe, the size of the countries versus like where we live. Do you know what I'm saying? It just, even the population areas are very difficult geography. So that's a good point. Any other thoughts that anybody has?
I would, given the conversation we had before we started, the difficulty in terms of having instructors, the difficulty in, when I look at these statistics, what it tells me is we need to re-look at how we deliver healthcare and also how we deliver and how we construct nursing. I think nursing, when we look at these statistics, has to be very different than the way that we've done nursing over the last 50 years. But I don't have an answer to how that will change. But I think the demographics really will push for some sort of major change in how we can see nursing.
Well, I think one demographic is that more nursing is going to occur in the community because people don't want to go to institutions. And I also think we're going to have to do more delegation. I think nurses are going to have to be comfortable working with population management and delegating to lesser prepared people. That's just one thought. Do other people have other thoughts?
Well, in terms of, of technology, we've already seen massive changes with that. And that just leads right into what you said about people being more at home and maybe not for mobility reasons or lots of other reasons, not being able to leave or not even wanting to leave and having some sort of a telehealth connection to their healthcare. So, I mean, that we've already seen a lot of changes. I think that we're probably on the tip of the iceberg of some of the changes that are yet to come.
We are. We
Yeah.
are. Right. So moving along,
Yeah,
I think one of
go ahead.
the, oh, did somebody want to say something?
You know, I
I
just
was
want to
just
say
thinking about
something.
go ahead.
I'm sorry. We have this thing about aging at home and how everyone should be able to age at home. But when you see how many people it takes to keep somebody in their home, I think we have to relook at what that even means. You know, because you have so many different people coming in to provide services to keep one person at home.
Well, I kind of have a vision that there would be some more congregate living or neighborhood kind of living, Kathy, and that, but I'm not going to be in a dorm room sharing a bathroom. Do you
Well,
know what I
that's,
mean?
yeah, I knew a group of women that nurse practitioners who all wanted to buy a condo building. And so
Yeah.
there was a condo for each one of them, and there was one extra condo for a nurse to take care of them all.
Yeah.
So, but I think we have to really like stop with the sentimentality kind of talk about what it really is or what it could be.
Right. And that's why I talk about that, the first 15 to 20 years of your retirement, you can do one thing, and then you need to look at what do you need to do later. So it's a challenge. So, Alzheimer's disease, I think, is going to probably be I think that may help make some of the changes that need to happen because it is exploding and it's going to just continue to explode. And we also have significant diversity gaps, as we've talked about, and there are also significant economic disparities, which are evident across the different population subgroups. So, 17% of Latinos and 19% of African Americans lived in poverty in 2017, much more, twice the rate among older non-Hispanic whites. So that's going to be a significant thing. And we also,
I'm sorry, Sarah, it's Celeste. Can I ask a question about Alzheimer's? Because I have seen those statistics, as we all have, on the slide previous to this. and I know we don't even really know like the root cause of Alzheimer's disease or anything, but what is, as somebody who works with this population, do you think this is because, as you just showed us, that the previous decades and generations, they never got to this age, so they never
That's
got
right.
to, or do
Right.
you think there's something that's actually
No,
causing this
no,
now? You
No,
just
I think it's because the greatest risk factor for Alzheimer's is age.
age. Okay.
So, everybody wants to know, what do I need to do? So 1 out of 6 people 65 and older have dementia. When you get to age 85, the Alzheimer's Association says it's 1 out of 3. I think it's closer to 1 out of 2. So age is the greatest risk factor. So people just didn't live long enough.
Long enough. Okay.
That's just, they didn't live. Everybody died, so it didn't happen. And I think Kathy talked about this. Older people require a disproportionate share of healthcare resources, 25% of doctor visits and over 35% of hospital stays. So I love to talk to the undergraduate nursing students, and I ask them what they want, where they want to work. And they all want to work in the ICU. And I'm like, well, why doesn't anybody want to work in geriatrics? And they're like, well, I don't want to do that. And I said, well, who do you think's in the ICU? So they have no clue. So I want to talk a little bit. So I don't know if any of you, I love to read Institute of Medicine reports. There was a major report in 2008 that talked about, really retooling, building our healthcare workforce and really enhancing the competence of people, developing and disseminating new models of care, and recruiting and increasing recruitment and retention of elder care workers. So if you have nothing else better to do, it's great. It's a great read. And there was also another study that was done about mental health and substance abuse workforce for older adults. That's really lacking. Geriatricians and geriatric nurses they're really very low numbers. And in fact, the APRN consensus model very conveniently removed the specialty of geriatrics. It changed it to adult geral. Pediatrics remains its own specialty, and neonatal remains its own specialty. So we even watered down the geriatric workforce issues for APRNs. And I'm going to try something. I always hate it when people do this, but have any of you seen this video? We're going to see if it works. Why is it not working? What am I doing wrong? Okay, so I have it set up so the sound should go. This is why a leading cancer doc says he won't get chemo. Just let's see. Hopefully you're going to, I think this is a really good.
Dr. Emanuel, there are a lot of
hear it?
interventions. I'm going to put them on the screen that you say when you hit 75, you're no longer interested in. Regular preventive tests, screenings, interventions, colonoscopies and other cancer screening tests, cardiac stress test, pacemaker, implantable defibrillator, heart valve replacement or bypass surgery, flu shots or antibiotics, ventilators, dialysis, surgery, medication. God forbid if you get cancer, you're just going to let it ride?
Yes, sir. And you know what, Michael, a lot of those interventions, they're not necessarily pleasant interventions, especially cancer chemotherapy. I'm an oncologist, as you mentioned, and I know a lot about them. And I think the real question is not at that moment. The real question is, how do you want to live your life? What does quality of life mean to you? And I'm pretty clear about what it means to me. And the reason I wrote that article was to suggest that people need to be clear about what it means to them. I wasn't telling everyone, do what I do. I said, you need to think about it. You just can't sort of blindly go into old age, which I think unfortunately happens to many, many people. And the medical system will do what the medical system does, regardless of what your philosophy of life is. And what I was urging people, think about what's important to you. What's important to me is to be mentally active, mentally engaged, doing what I can do to make the world a better place.
Had any of you seen that before?
The hardest thing.
Had anybody seen it?
No.
I had.
You had seen it, Kathy?
Yeah.
I have.
I've seen it too.
Yeah,
do you
I've
think-
seen it too.
What do people think about it?
Oh,
I thought that it was so blanket. It was so, I'm not going to do any of that at 75. And I think there's nuances, and he's not a nuanced kind of person. But the more I think about it, the more I think about how, so you have all these tests and it shows something, and then what are you going to do about what's
Yeah.
it going to add? And I think that we don't ask the questions like, well, if I get this treatment, this, but what if I don't get it, this, what happens? And to really consider what all the options are, instead of just blindly thinking that there's a best thing to do and you have to do it.
Right.
It was pretty extreme. He even said no antibiotics.
Mhm.
So
Well,
not even any really basic stuff.
right, it is kind of extreme, but another perspective to think about it is if sometimes if you didn't take the antibiotics and you passed away, you might be avoiding other problems that are going to come further in life.
Yep.
Do you know what I'm saying? I've made Kathy and Molly, and I think Heidi's have heard this. I don't want CPR. And the reason I don't want CPR, even at my young age, is there's a lot of anoxic brain injuries that happen. And I don't want to have that. So that's just a decision that I've made. And my family knows that. And it's just very challenging. But this fits into what I'm going to talk about moving into the next thing. So the Institute for Health Improvement, IHI, has developed a system called the Age-Friendly Health Systems. And it really focuses on 4 areas. And have any of you heard of I can't see them, Heidi, so have any of you heard of the Age-Friendly Health System, the 4 M's?
I have not.
Does anybody?
It looks to be new to the audience. So you are on to new things here, sir.
Well, and the John Hartford Foundation, which is a very significant funder of geriatric care in this country, they gave me a scholarship to get my DNP. These are the 4 things that have been recommended to focus on for older adult care. And the top one is what matters. Know and align care with each older adult's specific health outcomes, goals, and care preferences. And then medications, we overuse medications, mentation, prevent, identify, treat, and manage depression and delirium, and mobility. Keep people moving. I will add a thing about mentation. We have a tremendous amount of undiagnosed dementia. And that is a curveball that's going to send us over the edge. So the Age-Friendly Health System it's a clinical system level intervention, and they recognize clinical care based on settings that are working toward reliable practice of these evidence-based interventions for all older adults. And so clinics can do it, hospitals can do it. But what I thought was really kind of sad is I looked at their map of people that have been recognized or are participating. And in Minnesota, the only organization that they have listed that's doing it right now is the Minneapolis VA Community Living Center. And then there's 2 in North Dakota, Eastern North Dakota, and the Toma VA. So when I looked at this, the VA is doing this, but it's something we need to think about moving forward. And I get a little frustrated when I think about older adult care because everybody wants to become a magnet hospital. And I understand that, but I want to know, how does that influence or improve geriatric care? Because that's who's in the hospital, is older adults. So I have a little bit of a bias. And then, have any of you heard of the niche program?
Well, some I've heard of it.
You had, David? Okay.
I had heard of it, but that I'll go no farther than that.
Okay.
I've heard of it too. Actually, was involved in doing some work with that when I was still working at Mayo.
Mayo,
some
I
of my
believe Mayo
units.
was a niche, yeah.
Yep, yep.
So niche preceded the 4Ms, the IHI model, but it's really looking at a principles and tools to stimulate change in clinical practice at the institutional level. And it's an organizational intervention, and the goal of niche is to enhance nurses' knowledge and skills and to really position nurses as leaders who can systematically implement evidence-based practices to improve health outcomes for older adults. And this program has been undergoing some changes in the last couple of years. They use the model, I believe, of a geriatric resource nurse. And they're actually, this article by Comish and Pettis, oh, I'm sorry, the comma didn't go, really did. And there's a lot of nice alignment between niche and the age-friendly health systems. Like, here's the thing about what matters in the age-friendly health systems. And then niche has protocols and nursing management principles, and niche continuing education courses. So there's a real nice crossover, and I was glad to see that. And I think that those are, well, but all of these.
Heidi.
Yep, go ahead.
This is wonderful. Can you tell me, I see Tammy's on the line, and I think Tammy works in elder communities. So is this targeting nurses in any practice setting? Sarah, can you say a little bit about that?
Well, I think the niche program may be more acute care focused. I know IHI can be at any setting. But niche might also focus on long-term care. I can't speak to that as well. Is somebody's online, you said?
Tammy, you work in long-term care and, well, elder care housing, correct? I don't want to put her on the spot. Maybe she stepped away. But
Tammy.
I just, yeah, Tammy with a T.
Tammy, yeah. Okay.
And Tammy, of course, yeah.
I don't know. We can go to the website when we're discussing. Let's look through that. And then one of the biggest problems for healthcare when older adults are hospitalized is delirium. And so there's a wonderful evidence-based program called the Hospital Elder Life Program, HELP program, which is evidence-based, and all of these programs are evidence-based, that helps to target prevention of development of delirium and management of it. And it's organizations subscribe to gain access to program interventions. So it's a really great, and the American Geriatric Society has taken over the HELP program. Have any of you heard of the HELP program? Nobody's heard of it.
No, but I have seen family members suffer delirium, so this is fabulous.
Oh yeah, it's really great. And so it really, targets interventions by looking at a skilled nurse interdisciplinary team, and they utilize volunteers and that address a broad scope of geriatric issues known to contribute to cognitive and functional decline during hospitalization. And they have interventions such as orientation, stimulation, therapeutic activities, sleep enhancement, exercise and mobility, all of these really good things. So it's an evidence-based intervention, and it is, again, an organizational level. And then and I bet you've heard of this, Heidi. Have any of you heard of the Choosing Wisely campaign?
Yes.
We talk about that a lot.
Yes, yes.
Okay. Well, I just wanted to let you know that Choosing Wisely is really a good program. And there is a specific area for the geriatrics, like, so not recommending feeding tubes with people with advanced dementia, not using antipsychotics, avoiding using medications other than metformin to achieve a hemoglobin A1C less than 7.5, not using benzodiazepines, and avoiding use of antimicrobials to treat bacteria in older adults unless they have a UTI symptoms. And then I wanted to for us to talk about workforce. So one of the things that's really positive is the federal government has done it's called WEP funding, Geriatrics Workforce Enhancement Program. And we in Minnesota, at the University of Minnesota, there is a WEP program. And one of my concerns is I think it's more physician dominated, but Dr. Christine Talley at the University of Minnesota School of Nursing is one of the leaders on this. So it's a positive thing. It's doing really great work to try to help build the workforce. So it's good that we have this. And the other thing to talk about the workforce is, we really need to have a culturally competent workforce, and we need to implement culturally and linguistically appropriate services. And we need these recommendations. We need to train all clinicians in culturally competent and respectful care of diverse patients. And I think a big thing is, I love this term, implement task shifting and train multi-ethnic CHWs or community health workers to provide services for older adults to age in place. So when I've done a fair amount of research around social isolation in older adults, and one of the most successful interventions in working with diverse communities is to really take people from the community and train them and have them be the healthcare workers. And I don't know how many of you are familiar with the healthcare worker movement. Has anybody, I'm going to stop sharing now. Has anybody had experience with that community health worker movement? Heidi, what's been your experience?
Yeah, so when I was with Health Partners in Case and Disease Management, we had a team that would outreach to different low-income housing areas where we saw really disparities in care.
Mhm.
And we had the community health worker in the lobby help kind of build relationships in the community and talk about how to get to the clinic, which was blocks away, and that was an international clinic, because that person was trusted, could speak their language, could break down barriers, and it was really successful. Yeah.
Unfortunately, Heidi, I think they don't have that program anymore. I think COVID was the final straw, but there were some problems before that. So you're right. It was a highly successful program. And because the level of education and background of some of the community health workers, they weren't that expensive. So it was really cost effective, especially for the work that they got done in those diverse communities. So it's a shame that such a highly successful program got the axe.
I was on a webinar about that. That was a national one about community healthcare workers, and they talked about the pathetically low pay that they get.
Oh, they get
and how that they need to get funding
Yeah.
so that they can do the work they do.
They do need to get that. I don't know. I just heard on NPR recently. So we have this really substantial budget surplus this year. And we are doing a lot of really good things like school lunch programs for students and things. But one of the long-term care industry one of their goals was to bring the starting wage up to $22 an hour for long-term care workers. And that is not making any progress. So, and I don't know how many of you know that people are sitting in hospitals because there are no beds for them.
No,
And part of the reason there are no beds is because there's no staff.
Right.
Yeah.
Yeah.
So that's a big problem. So, I mean, I think we're going to have to deal with it. And I wanted to say, Heidi, I went back to your question. The niche program can be done in long-term care facilities. So that's something that can happen. So that's my slides. I'm sorry I breezed through them. So what are people's thoughts? What do you I'll just say my thought is I would like to see more health systems implementing the 4 M's and doing the niche model. Like I've tried to talk to one of our hospitals in Duluth that's on the magnet journey. And I talked to them about like trying to implement niche, because to me, that's like a nursing driven model and that would fit right in with magnet, but they're just like, we're going to do magnet. And it's like, how does that really change healthcare for older adults?
especially looking at the graph that you opened with.
Yeah.
There, I think, in having worked with niche for a while at Mayo, we did some special projects there with it. And I think you alluded to this earlier, but I think one of the huge barriers is that nurses do not see themselves as geriatric nurses.
They do not know.
We tried to get people in ICUs and other specialty areas in the facility to show any interest at all. And it was really a challenge because, they think they're an ICU nurse. They don't recognize that the significant portion of their population are elderly patients. And so I don't know how we overcome that, but I think it's a huge thing holding us back from people really embracing the importance of care for the elderly.
Right. And then when you think about some of the moral distress that nurses have, when I talk to my students, they talk about, that they're the ones when the people are in the ICU that the physician will not talk about end of life care, and they're doing it. And so it's like, I really like everybody in nursing school, in NP school, wants to be an FNP, a family nurse practitioner. Our adult general primary care program is going away, partly because the U and St. Kate's have increased their numbers. But I would say 50% of the FNPs say, well, I don't want to work with kids. Well, then why are you becoming an FNP? It's because they are more employable. But yeah, I don't know. So I agree. It's the nurses don't think they're taking care of older adults.
Hey, Berg, do you have any thoughts about this?
Yes, I do. I read about a model in Finland, which I think could solve a couple of different issues at once if it could be put together in regards to students who are in undergrad or graduate school in healthcare, or just wanting a place to live, would live in a senior living community. And in order to pay for their housing or in order to pay for their school, they would do a certain amount of shifts in the building. The intergenerational interactions also prove to be great quality of life outcomes for the seniors, and feeling, and as well as the students feeling like they were learning something different than they would from just living with their peers. So I think that could address some of our workforce needs, aides that are always high turnaround and struggling to make ends meet. There's your aide workforce right there. So I think it's a great solution. And I'm interested to hear everyone's perspective, or anyone who has thoughts about why it wouldn't work. What could we push out of the way or address?
Are you aware if it's been done in the United States at all? Is there a model that we could emulate here in the United States, or is it just?
Not to my knowledge. The closest thing I've read about was Marilyn Rance, who is an ANA Edge runner from Missouri, and she does have the School of Nursing that I believe she's the dean of, has a very strong involvement in a senior living community in Missouri, and it's pretty regular interaction of the students from the university and the senior living community. But it's one specific senior living community, and doesn't include housing. I'm not sure about tuition reimbursement, but when we're talking about nursing students who want to work with seniors, give them the exposure, give them the experience. I had one volunteer experience in my undergrad, helping paint old ladies' nails, and they're not hard to fall in love with. I love working in senior care. I think it's so enriching, but most people don't have that kind of experience. They might have 1-2 grandparents that they may or may not get along with or see more than every other holiday. So I think the potential's there.
I just
agree.
something in the chat from Winona State.
Oh, yeah.
This was on TV and it was just superb.
I
Mm.
remember seeing that, and I'm
Yes.
a Winona State grad
Yeah,
or alumni.
yeah, yeah,
And
wonderful.
and and the nursing home that I used to work at was the nursing home that they were having students live in. And I can't remember all of what they were expected to do. And I'm not sure if COVID changed all of that. But yeah, sounded like an excellent program. And I thought, boy, it would have cost me a whole lot of less money and in in living expenses if I had been able to live there. But yeah, it was the Watkins Nursing Home in Winona, and it was Winona State students.
Yes, it was really inspiring. And to hear them interview the students, I was just like, oh my goodness, those students could take care of me anytime. That was so compassionate and caring and loving. It was just, I was so impressed. And I was hoping that this model would be, you know, transferable to around the whole United States. It's just brilliant.
Cool. One other model I forgot to talk about, and I look at David, there are geriatric emergency rooms. And I don't know if you've heard of that, Dave.
Yes.
Yeah,
Yes.
and then they are certified as geriatric emergency rooms. And I mean, I don't think there are any in the Twin Cities. I can't speak for that or
No.
not, but you know,
No, I
just think, huh?
No, I don't believe there are. I think we've attempted to do some geriatrics within training for emergency nurses, but it's diluted with everything else.
Yeah.
There has been some work in the Rochester area around community paramedicine and having community paramedicine providers
Yep.
visiting different groups of people. And I think that's been fairly successful, although the funding stream isn't very secure for that.
Mm-hmm. That's a good thing. So what do you see as some steps that could be taken to help geriatricize our healthcare systems? What do you think next steps are?
You know,
Personally,
I worked
I'd
as
like
a
to
geriatric
see
care manager.
Personally, I'd like to see something different in how an insurance reimbursement, maybe something like a palliative-based model, so that part of the reimbursement is having the conversation about, you know, what kind of life do you want to have? How deep do you want to go in interventions? It's something that's more complex than, are you a DNR, DNI, or do you qualify for hospice, or do you qualify for home health? Well, maybe someone is in the gray area right before then, where they might need a little extra help, and you know, but insurance isn't going to cover that, or they're wanting fewer extreme interventions, and creating something along the lines of, let's make sure we're having this conversation. I think that most primary care doctors who work with the geriatric population believe in that already, to have the let's rephrase how we're looking at each of your conditions and what we want to do about it, and what are the effects of this medication, how many are you on, et cetera, et cetera. But I think we all know that money is the driver. We live in a capitalist society. You want to make something happen, you have to put money in it.
I will say that there is reimbursement for advanced care planning discussions. It's not great, but there is, it's like it's minuscule. But
like
I do a lot
basically.
Huh?
Like a code that you would submit with a
there is
claim
a
to get
code, but
reimbursed
I
for it.
do it as part of my regular care. So I think, I mean, I usually add, I mean, I can talk about advanced care planning and still talk about dementia as the primary billing diagnosis. Do you know what I mean? So yeah, I think we need to really move to getting comfortable talking about advanced care planning and goals of care. That's a really important thing. Yes.
I wish I saw more interprofessional teams at neurology clinics, at geriatric clinics, where there was a social worker on site, somebody that could help with decision making about, you know, is home right? Do we need to get home care involved? Do we need to get services involved? When my brother-in-law was diagnosed with advanced or early onset dementia, and we went to a neurology clinic in Golden Valley, he was, by that point, you know, it wasn't long for the service after that last visit, but the neurologist wanted to put him in an MRI for $3,000 just to see why he lost his words. And I said, well, will that prolong his life? Well, no, but it maybe will help us know why he isn't talking. And I said, well, that same $3,000 could give us, you know, hours and hours of home health care respite. Do you understand why we're declining that? And she was really rattled that I even declined it, as though nobody had ever done that before. So it's kind of an example of, you know, how sometimes people are cure at all cost versus, and I asked, do you have a social worker to help with this sort of thing? No, we don't. You have to call Alzheimer's Association. So, you know, kind of an example of, you know, we need to think a little differently about how we care for our elderly population.
Mhm. Yes.
Just following up on what Berg said earlier, you follow the money there. So the money is in the intervention, the MRI. It's not in being able to pay the social worker or other staff. So the money dictates where the work is done.
Yeah.
Are there many geriatric clinics? The reason I ask is in St. Paul, Highland Park. Clinic opened just in January. It's women's health, but it's called Herself Health. And it's for women 65 and older only. And it's not owned by any of the big players. It's not Alina, it's not Fairview, it's just independent. Are there others of that nature around, or is that kind of a pioneer?
There are some, but there are not a lot of them. I mean, they're there, but not many of them.
Well, I thought it was kind of a cool concept.
Cool. Somebody had put their hand up. I think Ozima had her hand up.
Yeah, I raised my hand. So I wanted to say something regarding what we do to incorporate the elderly adult into the healthcare system. So what I was thinking is, because you, according to your discussion, you were saying that the nurses that work in ICU, they don't think that the older adults are part of their care. So I was thinking that if the nurse educators can check their curriculum and include, I don't know whether they are giving enough education on that area about older adults. Yeah, so that when the student come, when they become registered nurses, they can be able to take care of the older adults. That's what I want to say.
Thank you.
Mm-hmm.
Any other thoughts? What do you guys think about the 4Ms model or the niche model?
I think that I know some provider groups who are following that, who just aren't necessarily signed up directly with it.
Right.
So I'm interested to hear what benefits someone by saying, sure, we're gonna, you know, put our name on your list and carry along the 4Ms with us and display it. I'm wondering how those partnerships occur so that that message can be spread.
I don't know. I think going to the IHI site, I can tell you as someone who's a geriatric focused provider, when I talk to people about the fact that I try to approach care from a geriatric perspective, they're really happy about that. Like the first thing often I'll say is, you know, I'm not about adding medications. I'm about getting rid of medications. And so I think people are thirsting for geriatric focused care. And I think the problem is it doesn't always, I mean, Medicare and Medicaid, providers lose money on it. So it's not sustainable. And so that's one of the challenges, you know, taking care of young working people and kids somehow brings the money in. But so I think we have to change the reimbursement system to make it sustainable.
I agree, Sarah, that seems to be the driver. And now that I have Medicare, and as a nurse, I should know some of these things, but I remember sitting down and trying to go through that very thick Medicare booklet to find out, I can't even remember exactly what it was that I was thinking about. I mean, my word, I mean, it would have taken hours to, and granted, I could have probably called somebody, but I also know sitting on a Medicare helpline for, you know, 4 hours isn't going to be very helpful by the time I'm done. So, I mean, it just, and part of my own experience is shadowed by what happened to my uncle in Canada. And in Canada, they do have some different criteria. In his 80s, he got colon cancer, and they did not do an operation and remove that. He lived probably, I think it was 6 years longer, and because he died in his early, maybe 91. And then when it came time for him to have a knee replacement, they didn't do that. His physician said, no, you've got this chronic disease. But they did send in a physical therapist to the nursing home where he ended up at. And I thought, you know, we would have probably taken care of the colon. We would have sent him for a total knee. And yet he had a very good 6 years with his family.
And he could have died from the surgery to have the colon cancer removed. I mean, I'm sorry, we torture people to death.
Yeah, and then infected his knee.
Yeah.
Martha put a comment in the chat that we should be publishing articles in AARP, which I think is a really good idea, so that patients can ask for things like the niche program and the 4 M's.
You know, AARP has some good relationships with nursing organizations. Like I'm a member of the Gerontological Advanced Practice Nurses Organization, and we have been developing some relationships with AARP. So I agree. I think that's a really good point, Martha.
That's my strategy now with, as you can see, I'm pretty much in this age group we're talking about. And I work with so many people and individuals who go to get healthcare and come out with piles of meds and more testing and no answers to their questions. And they really need to be able to feel comfortable standing up for themselves, saying, do I really need this? How will this medicine work with these other meds that they gave me in the other clinic? Because the medicine so many of my friends are getting is so fragmented. You know, they see neuro, they see ortho, they see GI, they see all these different people, and nobody works together except at Mayo. I really must, obviously Mayo's an exception here, but around town here, it's crazy.
Well, it's challenging. So I'm lucky in my clinical practice, I have hour appointments. I am known for having my appointments go longer. And as long as I do my charting on that day and I do all the checking with the other records, I can bill for it. But, you know, when I get home at 9 o'clock at night, it's hard to, I mean, part of the problem is that, you know, I call electronic health records, they're just like, I think it was Kathy maybe had said it. It's like a word processing silo. So was that you? Was that your term, Kathy? So, you know, it is hard to collaborate. One of the things that I do is I try to send people back to primary care. I don't always prescribe meds as the specialist. I think we spend way too much time on specialty care. You know, primary care gets 20-minute appointments. And You know, I see a lot of people with dementia. Not everybody in dementia needs to be seen in neurology. So, you know, I think we need to empower our primary care providers to be able to do the work that needs to be done in the coordinating. But instead we keep cutting their times and they are paid the least of the system in the system. So it's a challenging thing. It's very challenging. So we're at 8:01. So what's the next step? Should I shut off the recording?
I think you could.